everyone, and welcome to another insightful episode of MedSynapse podcast series. I'm Hetvisha, your host, and today's topic is one that affects a significant number of women but does not always get the attention it deserves, which is uterine fibroids. These non-cancerous tumors can cause serious symptoms like heavy bleeding, pain, and even fertility issues. But thanks to advancement in medical technology that we now have more effective and minimally invasive ways to manage. And to help us explore the latest developments, I'm thrilled to be joined by Dr. Rajesh Helavar, an esteemed consultant interventional and diagnostic abdominal radiologist at Manipal Hospital in Yashwantpur. With over a decade of experience in this field, Dr. Rajesh has been at the forefront of using cutting-edge imaging techniques and interventional procedures to diagnose and treat uterine fibroids. Dr. Rajesh, it is an absolute pleasure to have you with us today. Thank you for joining us.
It's my pleasure to be on this chat, Ms. Hetvisha. So thank you for the kind introduction.
Thank you, Doctor. Now let's dive right into our topic, Doctor. So in recent years, we have seen significant advancement in imaging technologies such as MRI and ultrasound, which have also improved the diagnosis of uterine fibroids. So could you share how these advancements have impacted the accuracy of diagnosing fibroids, and what are the key factors you consider when choosing the appropriate imaging modality for different patients?
Okay. Coming to the modalities that we use, most often, like you mentioned, we use ultrasound and MRI to evaluate uterine fibroids. CT is not the modality of choice, and moreover, it's got ionizing radiation. So we try to reduce that, and MRI and ultrasound are the modalities of choice to evaluate suspected uterine fibroids. The first go-to investigation is ultrasound, and it's very versatile. It's easily available. Takes a very short time to scan the patient, and we can assess the presence of fibroids, the location of fibroids with the ultrasound. Also look for the vascularity. The newer ultrasound equipment have improved the detection of vascularity, the blood flow inside the fibroid, which gives us an estimate about how well they will respond to treatment. So there are some newer technological advancements in ultrasound to aid us detect the blood flow very easily and to detect even low amount of blood flow. And we have new tools like fibroid mapping tool. Fibroids in different locations behave differently and give rise to different symptoms. So with the aid of a fibroid mapping tool, we can locate and store those and compare them in the follow-up studies. The other advancement that we have is 3D imaging, wherein we can use the ultrasound to do a 3D imaging rather than just a 2D two-dimensional scan. So the whole 3D image can be generated and look at the presence of fibroids and the mass effect it is having on the endometrium, or is it growing out. Coming to MRI is more objective than ultrasound. Ultrasound can be a little subjective. MRI takes a little longer than ultrasound to perform, but is a very excellent tool to detect the fibroids and also to differentiate fibroids from other mimickers, like for example leiomyosarcoma, especially with contrast, when the contrast agent is administered. So with the newer technologies in MRI, the scanning times are getting shorter and shorter. Maybe earlier we used to take about 20 to 30 minutes. Now within about 10 to 15 minutes we can finish a scan. And with the newer technologies and faster scanners, there is also development of dynamic contrast. So it measures how fast the contrast comes into the fibroid and gets retained or washed out. All these can be assessed, and this also helps us assess the vascularity, and in turn the response to the treatment can be gauged by the amount of vascularity, because if it's not vascular and if it's calcified, so those kind of fibroids may not need treatment. Coming to what do I choose when I see a patient with fibroid? Always it's ultrasound first. It's because it can be done in the office and that can be done quickly. And if I have doubts or if a definitive procedure is being planned, then we go for an MRI. So that's the sequence in which we work.
So now speaking of uterine fibroid embolization, which is gaining a lot of attention as a minimally invasive treatment option these days. So what patient characterization of fibroid features make someone an ideal candidate for this procedure?
Okay. So coming to before jumping to the patient selection, let's look at the symptoms so that it helps us to assess the patients better. So the most common symptoms are due to fibroids are one is menorrhagia, that is excessive bleeding. The second one is the pressure symptoms like frequency of urination and sometimes low backache and lower abdominal pain. So these are the symptoms that are caused by fibroids, and sometimes there can be issues with fertility as well. So now coming to the question of which patient characteristics do you choose? So according to the guidelines from multiple societies, including Society of Interventional Radiology, American College of Obstetrics and Gynecology, and the Royal College of Obstetrics and Gynecology, UK. So any patient who is having symptoms due to fibroid needs to be treated. And for all these patients with symptomatic fibroids, uterine artery embolization must be considered as one of the options, first line options, along with surgery as a treatment of choice. So when it comes to clinical practice, what we look at is there are some subset of patients in whom we will definitely offer, especially a woman post 40 years desiring to have a minimally invasive treatment for menorrhagia or pressure symptoms, definitively, because the risk of recurrence is extremely low. In these 40 years plus patients, definitely uterine artery embolization is the modality of choice for treatment along with surgery. The benefits are as good as surgery and the recurrence is very less. Now coming to the patients between 30 to 40 years of age or the early 30s or late 20s who have completed their family. So in those scenarios, we have to offer both surgery and uterine artery embolization, but a small subset of these patients, about 5 to 10% of them, may require a second procedure, because if by uterine artery embolization you treat all the existing fibroids, but because of the hormonal stimulation and her reproductive age group, she may develop another fibroid which may require treatment. The chance of that is less than about 10% with the current techniques. There is a third subset of patients who are not yet conceived and not have kids and wish to have fertility preserved. In these subset of patients, the guidelines are not very clear because one, the data is very difficult to generate. You can't have RCTs in these subset of patients willing to have fertility. And even in these patients whom we have treated for fibroid embolization, how many of them are willing to have pregnancy further and continue to pregnancy? These are difficult data points to measure, and the small time frame of the studies that we have done, like 1 year, 2 years, won't give us a complete picture. So you have to look beyond 5 years to get the actual data. So the data is not very clear. In these subset of patients, I would be very careful before choosing uterine fibroid embolization. This is about the patient factors. Coming to the fibroid factors, like I told you, while fibroid mapping, the fibroid can grow into the uterus, distorting the endometrium, and then cause menorrhagia, or grow outside and cause pressure symptoms. Sometimes the fibroid prolapses so much inside the uterine endometrial cavity that it's hanging like a grapefruit. So that's called a pedunculated fibroid. This is one scenario in which I would be careful and maybe avoid uterine artery embolization, because once this fibroid becomes devascularized or loses its blood supply, it may be expelled through the cervical canal and may require another procedure to remove that fibroid. So in these subset of patients, a pedunculated fibroid, or where it's hanging into the endometrial cavity, I would be slightly cautious in offering them fibroid embolization. And another one is where the fibroid is almost detached completely from the uterus and is hanging like what we call as a pedunculated and growing outside. Okay. So in these subset of patients also, where the supply might not be through the uterine arteries, we do not prefer to do uterine artery embolization. Rest all the patients with symptomatic uterine fibroids are candidates for uterine artery embolization for fibroids.
Yeah, that was a great explanation. And now, but then I also had one concern that are there any complications related to these UFE, and if there are, so how can these complications be managed?
Yeah. So when we do a fibroid embolization, what we are doing is we are cutting off the blood supply to the fibroid. Okay. So it's called ischemia. So whenever there is an ischemic event or there is cell death, there is pain. So pain is most common complication of uterine fibroid embolization. The larger the volume of fibroid that we are embolizing, the higher the pain. Okay. So smaller fibroids like 4 or 5 centimeters may not be very painful, and maybe the patient can go home on the same day. Larger fibroids, especially when the volume is more than 1000 cc, the pain can be quite severe. So other than that, extremely rare chance of infection is possible, but we do protect them with prophylactic antibiotics. So coming to how do we manage pain? So first is sensitizing the patient that there may be pain, and during the initial outpatient visit, so that we set their expectations right and we assess the kind of a person we are handling with. If the patient is very sensitive, does not want to have any amount of pain, so then maybe our protocols for pain management will differ. So what we'll do is on the day when the patient comes in, so we will start with pre-medication and the person will see a anesthesia team. Our anesthetist will assess the patient for suitability for the mode of anesthesia. The most common mode of anesthesia that we use is IV sedation. Okay, so here the patient receives the pain medication as soon as, or even before the embolization starts. As soon as the procedure starts, the patient receives pain medication and will receive pain medication during and after the procedure. So the advancement is that we do not want to load patient with a lot of anesthesia medications, analgesics. So we let the patient be in charge of the pain. So we use something, our anesthetist and us use together, something called as patient controlled analgesia, where a pump is loaded with a medication that delivers analgesia. And if the patient has pain, only then the patient will click a button and she will receive the pain medication. If the patient is pain free, she did not click it, and there are safety protocols for this as well. So the patient is completely in control of her pain and can get medication on demand, rather than asking a nurse to give pain medication and all that. So she's completely in control. Most of the patients are pain free or have minimal pain by the end of by the evening of the procedure, and they can either go home on the same day for smaller fibroids, or slightly larger fibroids, they go home on the next day. Other than pain and very rare chance of an infection, the complications are extremely low. If we do embolization for a pedunculated fibroid, like I told you earlier, she can expel the fibroid. That's a possibility if a case selection is not appropriate, or for some reason the submucous fibroid completely devascularizes and falls off.
Yes, that was very insightful, and I think in all of this, safety is the top priority for everybody.
Yes.
So, as you were mentioning about the pregnancy during UFE procedures, so what advice do you provide to women who are considering this procedure but are worried about their fertility?
So first, when a woman with fibroid comes and sees us, who's yet to conceive or wishes to have a family, comes to us, we first sit down and discuss with her what are her few requirements for a future. She's really considering pregnancy in the near term? And then we, as a team, our gynecologist also sees them, and we sit down and discuss with them about the actual scenario, how big are the fibroids, how easy or how difficult is the surgery, how easy or difficult is the embolization, what are the expectations. We set the expectations, and we ask the patient to make an informed choice regarding embolization versus uterine myomectomy. So we do give them all the information that they have to make a decision, and most of our patients choose embolization, and some of them choose surgery as well. So this area is a gray area. So a team meeting and a multidisciplinary meeting is held between the gynecologist, the obstetrician, and the interventional radiologist with the patient and their family, so that because data is not very strong, even there is meta-analysis which says that the rate of fertility in patients with undergoing uterine fibroid embolization for fibroids is same as that of general population. There are some small reports which again, due to lack of numbers, say that there is some amount of preterm labor and some amount of what you call increased amount of abortions of marginally following embolization, but the level of evidence is not that great. So we present all this to the patient and they generally choose, and we go ahead with their choice and we support them throughout their journey.
But then it is again very difficult if they want to choose the option of pregnancy, right? Yeah. But also, how common is it for women for the age of fertility, at the age of fertility, to diagnose with uterine fibroids?
See, what we have to understand is that uterine fibroids are found in about 40% to 50% of the reproductive age group women. Okay, so just the presence of fibroids is not an indication to treat. So if you go to the age of 50 years, maybe 50 to 70% of the women will have fibroids. Okay, so that's the reason why we always stress symptomatic fibroids. If the fibroid is symptomatic, so even in women considering pregnancy, and if on a routine prenatal scan they have a fibroid and it is small and not indenting on the endometrium, not large, not multiple, not distorting the endometrial cavity, most often the pregnancy outcome will be good. And what it needs is just monitoring rather than treating that fibroid, because the patient is planning a pregnancy. So most often these are innocent bystanders. They are sitting there and they may not cause anything. About a third of these fibroids during the pregnancy can enlarge, and post-pregnancy they can reduce in size. Okay, so in some small subset of patients where there are large number of fibroids or the large size of fibroids, and the patient has come to us already in a state where she's conceived, what we would say is we would advise them, if there are no other risk factors, to continue the pregnancy, and if there at all there is a chance of increased bleed during the pregnancy, we will be on standby to provide uterine artery embolization to cut off the blood supply to the fibroid and reduce the bleeding. That is a different scenario. It's also uterine artery embolization, but for postpartum hemorrhage caused by uterine fibroids. So we would do that in that scenario. So yeah.
Every scenario and every patient's risk factors would be different depending on the fibroids.
Yes.
That makes a lot of sense now. Now, let's pivot slightly to non-invasive or minimally invasive treatments for fibroids that are currently being researched or in clinical practice. So could you tell us about some of the latest innovations in this area?
Yeah. So the latest innovations, apart from uterine artery embolization, is nowadays the ablation, where a needle is inserted into the fibroid and the fibroid can be killed by generating heat, or that is called ablation, thermal ablation. Okay, heating the tissue is becoming much more popular. So for uterine fibroids, as a treatment for uterine fibroids, so that is one of the latest things that's coming up. I have not much experience personally, but I have seen the recent articles in literature. It looks a very promising modality, and in that too is a minimally invasive modality, can be done in the hospital, in daycare, and the patient goes home the same day. This procedure is similar to what we do for other organs. For example, we do what is called as ablation for hepatocellular carcinomas, and we also do ablation for benign thyroid nodules. So we have a lot of similar procedures elsewhere in the body as well. So they have excellent results, and they are for both benign conditions like in the thyroid and malignant conditions in the liver. So that same principle is applied in the uterus to burn and kill the fibroid. Not burn, but ablate, specific controlled increase in temperature to cause cell death. So this is one of the upcoming modalities that You can look forward, maybe in the next 5 years, this is going to be quite popular.
Yeah, that sounds like an exciting option also. Now, could you elaborate on when you would recommend this over a traditional interventional radiology, like methods like UFE or something?
I think the data is yet to come out. So once the data is out, maybe the area of ablation that we need to do, with the devices also for ablation getting better, maybe currently for smaller fibroids, ablation may be a modality of choice, and the larger it gets, so maybe fibroid embolization maybe still be a viable option.
Yeah, that makes sense also. And as we wrap up today's session, I would like to thank Dr. Rajesh for sharing your knowledge and insights with us today. It's been an absolute pleasure, Doctor, to have you today.
Pleasure is mine. Thank you, Mr. Hetvisha. So have a good day.
Thank you. And thank you to our listeners for joining into today's episode of MedSynapse podcast. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed and stay healthy.